medications in the elderly, so I'll let you.
All right, thanks.
You know how to work the controls. Yeah.
Okay, so this isn't related to medication in the elderly, but I just thought for fun we would start with a comic. So Gary Larson's kind of my favorite. I'm nerdy and I think he gets like that, so just All right, so thank you for inviting me here today. When Ellen invited me, I kind of was trying to think how to make this a meaningful talk with you guys. And so, you know, kind of wrapping my brain, like how does therapy, like what do you want to know about medication? So I kind of did some looking at the research and medications and therapy and that kind of stuff. And the thing that kind of settled with me, and I think it's been settling with me a lot lately, is talking about the why. So why are medications differently and how are they differently? And so kind of giving you that sort of information so that you can make more meaningful decisions when you're talking with your patients. So that's really kind of what I'm going to try to hit on today. So my objectives are to describe medication-related changes in the elderly, and then identify and apply tools for appropriate medication prescribing in the elderly, and then just something else that seems that we talk a lot about is falls in the elderly. So I'm going to talk about the role of medication in falls. Right, so we have a changing population. The elderly are an extremely large and continuously growing population. As evidence-based guidelines are being developed and they're being improved upon, patients are living longer, right? They're getting their medications, they're living longer. So we're seeing a lot more elderly patients. The average life expectancy in the turn of the century was 49 years old, which is kind of unbelievable. And in 2003, the average life expectancy is 77 years old. So you can see our population has changed. And medications, like I just said, we're using evidence-based guidelines in these medications, and one of the key parts of evidence-based guidelines is medication. So we're seeing a lot more medications in these patients. So you can see 72% of patients over 55 are using one or more medications, and 20% are taking 4 or more medications. And this actually seems a little low to me. I'm thinking the numbers might be a little bit higher than that, but I think it's just a good perspective to give you that these are older patients and they're taking a lot of drugs.
Is that a consistent dose or aspirin every once in a while?
So that's any medication. So an aspirin, being prescribed medication. So medications on a daily basis. I see what you're thinking. Took a second. So why do we want to talk about medications in the elderly? Why don't I just talk to you about medications and then we can apply them to the elderly and then it's kind of simpler, right? So this is why, because most drugs are not being studied in the elderly or in patients with on a number of medications or a number of comorbidities. So if you're looking at, oh, this just got really loud. Don't scratch my arm anymore. So if you're looking at trials and clinical trials and you're looking at the inclusion and exclusion criteria, elderly patients, patients over 65, are generally not included in those trials. Or if they are, patients on multiple drugs, like you'll see in the trials. They excluded patients on anticoagulants. They excluded patients on anti-seizure meds. So there's a high number of exclusions. So taking these studies, it makes it harder to apply them to elderly patients. Also, elderly patients have changes in pharmacokinetics and pharmacodynamics. So why am I throwing all these big words at you? So when we're talking about pharmacology and the study of drugs, these are the key words that we want to talk about, is kinetics and dynamics, and we'll talk about those a little bit more. Elderly patients are at an increased number of meds, so when you're on more meds, what happens is you get more side effects and you get more drug interactions. So it's not simple like 1 + 1 is 2, it's 1 + 1 is 2 plus 10 other things are going on. And elderly patients are more susceptible to medications in general. So if you say, I'm going to put you on an anticoagulant, you're going to potentially experience bleeding. Elderly patients are more likely to experience bleeding than younger patients, so they're going to be more susceptible to medications. So pharmacokinetics. So pharmacology is study of medicine, like I just mentioned. There's 2 parts of pharmacology. There's pharmacokinetics, and this is kind of an easy way to think about it. It's how the body processes the drug. So when I think about kinetics, I think of what the body does to the drug. That's kind of an easy way to think about it. So in terms of kinetics, there's absorption, distribution, metabolism, and excretion. So these are the key terms and the key parameters that we want to think about. And every drug that is approved by the FDA has pharmacokinetic studies. So I can look at Lipitor and I can see what the absorption of Lipitor is, but I can see all of these things that are defined in the package insert. But again, these are defined in young, healthy individuals. They're not defined in the elderly patients. So the first parameter that I want to talk about is absorption. So absorption is how fast the medication gets into the bloodstream. When you're thinking about absorption, it doesn't matter for an IV drug, right? Because where are we putting an IV drug? We're putting it right into the bloodstream. So this is mainly, we're talking about oral medications, but we could talk about different administration, like sub-Q or rectal administration. So the way that the drug is absorbed in the body is through the GI tract, and the GI tract changes with age. So when we have aging, we have decreased GI motility and decreased blood flow. So let's think about that. What does that mean? Well, the place that the drug's getting absorbed, the drug's hanging around there longer, so it's going to be slower absorbed into the blood, okay? The other thing we see in elderly patients is we see an increase in the pH in those patients. So in their stomach acid, their pH is higher in their stomach, which matters for some medications because they're absorbed better in an acidic or a basic environment. So it's something else to kind of think about is patients, their pH changes, and so that's something else that's changing with absorption, right? We have elderly patients that are taking drugs that change the pH in their stomach. So that's something else we have to think about with absorption is, are they on an antacid or are they on proton pump inhibitor like Prilosec? Like, who do you know that's not on Prilosec, so these are things to think about, or are they on Zantac? So these are all things that are changing the pH in the stomach that's going to change the absorption of their medication and how fast their medication is getting into their blood. Also, kind of related to the absorption is other problems that we see in a lot of elderly patients. So they can't swallow the pills, so that's something we see. Poor nutrition, we're going to talk about that a little bit later, but that's something else. And patients have feeding tubes, so this all affects the absorption. So where is it being delivered with a feeding tube is going to change the absorption of the drug. Interestingly enough, absorption is the parameter that's least affected by aging. So we can say of all of them, this is the least affected by aging. Just the kind of like housekeeping, I don't know why I like that word. If you guys have questions, then you can just ask me, and I like questions, so I get off track, but I like questions. All right, so the next parameter we're going to talk about is distribution. So where the drug goes after it enters the bloodstream and how it gets to the site of action. So this is important because we need to know how a drug is getting to the site of action, right? And just kind of as why is this all important to think about? Is think about medications, and we'll talk about pain medications, right? Like you want to know if your patient's taking a pain medication, when it's going to be at its peak effect, right? So you want to know the onset, right? You want to know the absorption. You also want to know when it's going to start working fully. So you want to know when you're going to see, when I said peak effect. But first we want to see onset, when it's going to start working. You want to see its peak effect, when you're going to see maybe the most effect for your patient so they can get through therapy the best, or maybe when you're going to start seeing side effects like dizziness. So, and then also, like you want to know the half-life. How long is that drug going to stick around? Like if we're doing therapy for 2 hours, am I still getting an effect from my medication, or am I anticipating this medication's gone and, we need another drug? So, just trying to make it relatable. So when we talk about distribution, the key term that we use is volume of distribution. And the way to think about that is the amount of drug in the body relative to the concentration of drug in the blood. So you can see here, these are kind of the spaces that the drug is distributed to. So we have the blood, we have the various organs in the body, which is body water is being defined as. We have the general organs like muscle, and then we also have fat, that's another space. So these are all of the places the drug are going. And just for fun, all of the drugs don't distribute the same way, right? So volume of distribution, and distribution in general is affected by protein binding, pH, and then also the type of drug, like if it's a water-soluble drug or a lipid-soluble drug. And again, this is important because we need to determine the dose that's necessary to achieve the effect for the patient. So in elderly patients, we have changes in muscle mass, right? So when a patient gets elderly, what happens to their muscles? Does it go up or does it go down?
Down.
Right, exactly. So we're seeing a decrease in their muscle mass. Also, their body fat, what's changing with their body fat? Is it going up or down? Up. Body fat up, yeah. Sorry, think for a second. So some drugs are distributed more into body fat, like Valium, for example. That's a really, you guys see Valium? Do you use Valium? Okay, not personally. So Valium is a drug that's distributed into body fat, okay? So when you're taking a drug, when you're giving Valium to an elderly patient, the drug is going more into the body fat and staying less in the bloodstream. So are you going to see more of an effect for the patient or less of an effect?
Well, if it's Valium, we can see more.
Well, you think you'd see more. That's for other reasons you see more. But you're actually going to see less because there's less of the drug that's staying in the bloodstream to get to the site of action. Yeah, exactly. So it's important to think about. Another change in elderly is they're producing less albumin, right? So albumin is a protein that we have in our blood. A lot of drugs like to bind to albumin. So a good example of this is phenytoin. So we use phenytoin for seizures and some other stuff, but phenytoin is binding to albumin in the blood. If you don't have albumin in the blood for the phenytoin to bind, what's going to happen? You're going to have more. So you're going to have more phenytoin that's hanging around in your bloodstream, and guess what the more phenytoin that's hanging around in your bloodstream is going to do?
Side effects?
Yeah, it's going to give you more side effects. So these are kind of different things about distribution of drugs that we want to think about in an elderly patient. So a lot of these things are changing the dose that's necessary. So we just said, for some drugs you're going to get more of an effect, for some drugs you're going to get less of an effect. But ultimately it's kind of unpredictable. So what do you do in these elderly patients? Is you start with the dose and you titrate to give them the right effect. So don't feel depressed about all of these changes that I'm telling you. There's nothing to do about it. All right, so the next thing that we're going to talk about is metabolism. So metabolism is when you're converting chemicals from one form to another. And in our body, the primary organ that's doing metabolism is your liver. So in your liver, there's two types of metabolism. You have oxidation, which is done primarily by the CYP450s, the cytochrome P450. So that's an enzyme in your body, right? And you have tons of these enzymes that are moving around and ready to convert drugs for you. And so when the CYPs are involved, there is actually converting to an active metabolite. So they're taking drug from a less active form and making it a more active form, right? Also in your liver, you have another phase of reaction that's called conjugation. And so conjugation involves, it doesn't involve these CYP enzymes. And so that's usually converting to an inactive product. So these are the two types of reactions in your body. A lot of times, drugs will actually use both. They'll use both phase 1 and phase 2 types of reactions. So why is that important? It's important because a lot of drugs undergo metabolism, especially the CYP enzymes, right? But another reason it's important is a lot of drugs change the way that CYP enzymes work. So some drugs are called inducers, and they're going to make these CYPs go on overdrive, and they're going to work really fast. And so they're going to convert to your active drugs really fast. So you might say, well, I gave this, the usual onsets in an hour. Why is it working in 20 minutes? It's because these CYPs are on overdrive from this type of drug interaction. Also, there's inhibitors, which obviously is the opposite effect. So it's going to make these enzymes work really slow. So you're waiting to see an effect. It's not working. It's probably because, or it could be because of one of these drug interactions. Other changes we see in aging and metabolism is your hepatic blood flow is reduced. So the drugs get into the liver slower to be converted or to not be converted or activated or inactivated. And then just in general, because you're older, your body's making less enzymes in general. So that's something else that's going on in the elderly. Just one more thing about the liver too. So these changes in elderly are kind of difficult to predict. Like we can look at patients and say, this, what we're talking about here, excretion, and look at their renal function, and we can say, oh, that's their creatinine clearance. that's how well their kidneys are working, right? Sort of. So with the liver, it's not that obvious, right? There's the Child-Pugh test, which can tell you how well the liver is working, but for the most part, there's not real good tests that say your liver is working really well, or unless your liver is working really bad. So that's kind of something else to think about. So excretion is the elimination of drugs from the body. The kidneys are the main way that we do that. Again, I just said it's more predictable than the liver, so we can figure out how much you're clearing of a drug a couple different ways, right? So we can actually collect your creatinine for 24 hours. That's the best way to do it, but not very practical in most instances. And then we also have calculations that we can use. So the Krakow fault and the modification of diet and renal disease, or the MDRD. What's nice about the FDA in this situation is they have given us information about how drugs change in these patients, right? So we can say, for this patient, their creatinine clearance is 30 mils per minute, and so we should use this dose of the drug. So that's kind of one of the nice things about excretion is there's a little more information available. And then the half-life, so what are the end effects about a patient not being able to clear the drug is the half-life is increased. So, these patients that, for example, opiates are hanging around for days and they should be hanging around for hours. That's kind of what we're seeing is the half-life is increased and these drugs are hanging around for too long or longer, or I guess it's relative. So that's the kinetics of it. So essentially we see a lot of changes in drug kinetics. A lot of them are difficult to predict. There are some that are easier to predict. So what can we do? Because now everyone's feeling like there's no hope. And so the only thing that we can kind of do is titrate a drug. So you start with the low doses and you go up to the effect that you're looking for, and you try not to hit the dose where you're getting the side effects from. Okay, so the next thing is pharmacodynamics. So I hope everyone will leave today and be like, do you know the pharmacodynamics? And throw around this terminology, and that'll be, and you can call pharmacy, and I'm sure they would love to talk to you about it too, because we love talking about it. So pharmacodynamics is how a drug affects the body. So I just told you kinetics is what the body does to the drug. So dynamics is what the drug does to the body. So does that kind of make sense?
Yeah.
Okay. So aging, when people age, we see more or less sensitivity to a drug. And that's kind of generally predicted by receptors. So receptors, the drug has to hit the receptor, the chemical hits the receptor, and then we're getting the effect that we want, right? So when you're older, there's less receptors floating around in your body, and also those receptors are generally less sensitive to the drug in your body. So that's kind of why we're seeing pharmacodynamic changes. Because of the pharmacodynamic changes, there's a higher risk to experience the adverse effects, and it's a little bit difficult to predict what's going to happen. This is like my mantra today. So some pharmacodynamic issues, just to kind of talk a little bit about them, is orthostatic hypotension. So we see that a lot in antihypertensives, and we'll talk about that a little bit later. But it's an added effect at lowering blood pressure, and so that's why you're starting the elderly patients with really low doses, like amlodipine. What happens when you give someone 2.5 milligrams of amlodipine? They stand up, they get dizzy, and they fall over. So, we're starting with these really low doses, and we're increasing the dose to where they can tolerate it. Propranolol and beta blockers are kind of weird because the beta receptors are less sensitive, so you actually need higher doses of propranolol. Anticoagulants, this is something we see greater sensitivity to drug action. So I'll talk about Coumadin because you guys probably still see a lot of patients on Coumadin. So if I give an elderly patient 5 milligrams of warfarin, in 3 days I'm going to look at their INR, and their INR is going to be 4 because that's the propensity to bleed. And so I'm going to see a huge effect. If I give a young person, like a 40-year-old male who's 200 kilograms, 5 milligrams of warfarin, in 4 days I'm going to look at his INR and it's going to be 1.4 and it's not going to go anywhere. And so it's kind of, as you see in elderly patients, they're a lot more sensitive to the effects of these drugs. And then diuretics is another class of medication. So you see patients that are greater sensitivity to drug action. So they're a lot more likely to get dehydrated, right? Or they're a lot more likely to have electrolyte imbalances. So it's just kind of helpful to see that, in young people you're going to see one thing, in elderly patients it's a whole different ballgame. Adverse drug reactions is kind of another thing that are different in the elderly. So if you're any patient taking a medication, your risk for developing an adverse drug reaction, I'm just going to call them ADR for the sake of speediness, your risk of developing an ADR is 20%, which is kind of high, right? So that could be anything. That could be like your stomach's upset, or you have a headache, or anything like that. Your risk is 20%. So as you get older, the likelihood of an adverse drug reaction is much higher. So in a hospital, there's 10.7% of elderly patients will experience an ADR that requires hospitalization, and 5% of the general population will experience an ADR that requires generalization. And so, interestingly enough, the more medications we're on, I just told you before, elderly patients are taking more medications, the more likely we are to experience an ADR. So if you're taking 2 to 3 medications, your likelihood of experiencing an ADR is like 22%. If you're taking 6 to 7 medications, your likelihood of experiencing an ADR is 100%. So it's kind of helpful to know the more medications you're on, the more likely you're going to experience an adverse drug reaction. So these are kind of, I try to think about what drugs are you commonly seeing the most, and I know there's a lot of elderly patients because you're, the community homes and stuff. So I'll try to focus a little bit on what meds you're commonly seeing. But if you're like, what about this? And it's killing you, then just shout it out, and we can talk about that too. So anticholinergics, that's a side effect that we see a lot. That actually in the elderly, I would say is probably one of the most, terrible side effects that those patients can experience. So with anticholinergic side effects, we see dry mouth, blurred vision, hypotension, glaucoma. If they have glaucoma, their glaucoma is going to get worse. Their intraocular pressure is going up. Sedation, confusion, and disorientation. And what's kind of terrible about a lot of these side effects is they're insidious. So, they might be fine for a couple days or a couple weeks or a couple years, and then they're going to experience confusion or sedation, and it can be related to these anticholinergic meds. So common meds that we're talking about, like Benadryl. And I'm not saying don't give Benadryl if a patient's itching or if they're experiencing, an allergic reaction. Those are appropriate uses of Benadryl. But giving Benadryl for sleep every single night for a patient, you're putting a patient at a higher risk, an elderly patient. Also antipsychotics, antidepressants, especially like SSRIs, and also tricyclic antidepressants. And then over-the-counter cough and cold preparations is another one that causes a lot of anticholinergic side effects. So, and I guess we'll stop here for a second. So knowing this, like what would change? Like if you guys know, this patient's on Benadryl, like, do you think that there would be a change in your practice or a change in the recommendations? And I'm like, you don't have to answer, like, it's not a pass fail or anything like that. But, there's some things to think about is what would change in your practice if you're seeing this patient's on Benadryl and they're experiencing these kind of side effects. Mental status changes is another side effect that we see a lot. Again, it's confusion, sedation, delirium. And essentially, any drug that we just talked about that causes the anticholinergic effects is also going to cause these mental status changes. Also, muscle relaxants, that's a huge one that causes mental status changes. And then drugs that can affect electrolytes. So that's a little bit for a different reason. So Lasix is an example of drug that, if a patient's severely hypokalemic or really low potassium, you're going to see a mental status change in those patients. Orthostatic hypotension is another change, or another side effect that we see in patients. So sudden decrease in blood pressure, dizziness, and falling down. And that's really common for blood pressure medications, narcotics, phenothiazines. And, so who cares? Like, they're a little dizzy when you give them the medication. And we give young people medication, and why aren't they having the side effects? And a lot of it's because your body has a compensatory medication, sure. It has a compensatory response for these medications. So when I'm giving these to a 40-year-old, his body's able to make changes in like the angiotensin-renin system, where in elderly patients, they have a blunted response, so they're not able to compensate. GI disturbances is another side effect, so constipation, diarrhea, nausea, vomiting. So diuretics are common things that cause GI upset. Anticholinergics, antibiotics, narcotics, that's a huge one. So we see a lot of GI constipation in patients taking narcotics. And the end result of that is patients will probably stop taking them. So if they're taking a medication for long enough and they're getting severely constipated, they're probably going to stop taking this medication. And then cardiac, or they'll come back in the hospital. Cardiac changes, prolonged QTC, arrhythmias is kind of the common side effect that we see with cardiac changes. And so a lot of the antipsychotics, you see that list, a lot of the behavioral health medications can cause changes in the QTC prolongation. A lot of patients on head pain are on medications that can prolong the QT. And there's a couple antibiotics that can prolong the QT, like ciprofloxacin is a good example. So all of these medications added together can cause cardiac arrhythmias. Okay, so we talked about some drug side effects, and patients that are older, they have a lot of diseases, they have a lot of medications, and unfortunately, they also have a lot of medications that can make some of their diseases worse. So if a patient has diabetes, and we're giving them steroids, so we're giving them Salumendrol, right, or we're giving them prednisone, what happens to their glucose when they're in the hospital? Yeah, it goes way up. So it causes drug-induced hyperglycemia. So that's something, drug and disease state. Also, antipsychotics is another thing. That's not as acute as we see with steroids, but if a patient's long-term on antipsychotics, eventually they're going to develop some sort of abnormality in their metabolism. So eventually, probably those patients will develop diabetes. Osteoporosis, if we're giving patients steroids and they have osteoporosis, they have increase in their fracture risk, right? You guys probably see those. Constipation, anticholinergics, antihistamines, and narcotics, they can all, if a patient has underlying constipation, then again, this is an additive effect that we see. Antipsychotics and Parkinsonism. So a lot of the antipsychotics can also cause movement disorders, which can exacerbate Parkinson's disorder or Parkinson's disease. NSAIDs is a drug we see a lot in elderly patients, and that can cause hypertension by increasing the fluid that the body's retaining. So if a patient has underlying hypertension and we start giving them ibuprofen every day, eventually we're going to see an increase in their blood pressure. And then BPH, if a patient has BPH, again, anticholinergics can exacerbate and cause more urinary problems. Do you guys have any questions about any of those? Or?
Yeah, I do.
Yeah.
On osteoporosis
Take a
with
drink.
corticosteroids,
Yeah.
what's the length of time that somebody would have to be taking that before the side effect is seen?
So it's usually long term. So it's not with short term. It's usually 3 or more months is kind of where they say that's going to become a risk for taking, they consider that long term.
Okay, thank you.
Yeah. But their glucose starts right away. So another concern that we see in elderly patients is compliance and are they taking medication. So I just told you they're going to have a lot more side effects and now we're wondering if they're taking their medications. So that's a challenge when we're looking at patients and seeing are we getting the full effect from their medications, is thinking about actually are they taking it. And the elderly population is more prone to compliance issues for a couple of reasons. First of all, because they're taking more medications. So as patients, the number of medications they take daily increases, their risk for non-compliance also increases. So that's kind of problem barrier number one that we see. And also health literacy is another thing. So, talking with patients about medications, if health literacy is a barrier, then they're going to be less likely to be compliant from their medication. I thought this was really interesting. It said 25 to 50% of patients that are taking statins discontinue within the first year of therapy. So, statins, a lot of these are for diseases that are for lifelong treatment of diseases, right? And thinking about 1 in 2 patients are going to stop taking their statin is kind of interesting. Okay, so now everyone's thinking, what can we do? So there's 2 interesting, maybe 3, we'll call it 2. There's 2 interesting tools out there that have been developed, and they're kind of tools for us to assist when looking at medications in the elderly. And so they're tools that can either decrease side effects, decrease prescribing inappropriate medications. So those are the Beers criteria and the stop-start criteria. So has anyone heard about either one of these, or maybe a little bit? Okay. So the Beers criteria was revolutionary. So it was developed in 1991 by a geriatrician, and it was just updated in 2012. So are you guys familiar? You guys obviously are familiar with the senior ER here, right? So one thing is one part, I know therapy has a part of it, right? And then pharmacy also has a part of it, right? And so when the pharmacists are looking at the drugs, essentially they're using the Beers criteria to identify potentially inappropriate medications. So it's a tool that we can use all the time to avoid side effects for medications. So if you guys wondered what pharmacists do with senior year, that's what it is. So these are, like I said, potentially inappropriate medications for use. And it's essentially medicines where the risks are outweighing the benefits in these patients. And the goal is to just improve prescribing. And it's not meant to be like a punishment, like how could you prescribe this drug in these patients, but it's just to improve prescribing in these patients. And you know, before this, no one ever said elderly patients should be taking different medicines or shouldn't be taking these medications. So this is why this is really revolutionary. So the newest guidelines, they're a little different. There's 3 categories. The first category are medications that pose high risk or adverse effects or appear to have limited effectiveness. The second one is drugs that are inappropriate for certain diseases. So I just told you before that, you know, some drugs exacerbate certain diseases. So these would be the kind of drugs that are playing in here. And then the third are, they might be appropriate, but use them in caution. So there's 53 meds in the first 2 categories of probably don't use it. And then in the third category, there's 14. So let's talk about a couple one of these drugs. So nitrofurantoin. Are you guys familiar with nitrofurantoin? So if you have a UTI and you go into your doctor and it's uncomplicated UTI, they'll probably give you nitrofurantoin because it's a pretty first-line drug for a UTI. In elderly patients, they probably shouldn't be getting nitrofurantoin. The reason is it causes pulmonary toxicity in patients. It accumulates in elderly patients. And I think this is really the clutch of it. If you're elderly, where do medications need to work if you have a UTI? In your bladder, right? Like you want the drug to get to your bladder to treat the bacteria. Well, it actually doesn't get to your bladder. So in elderly patients, they can't take up the drug to get to your bladder, so it's not acting at the site of action. So that's kind of a good example of a drug that wouldn't be appropriate for use in elderly. Antipsychotics, especially if you look in nursing homes, there's a real push from CMS and the government to avoid antipsychotic prescribing in an elderly patient. And there's certain criteria that they have to evaluate after a certain number of months. Are they really still on the antipsychotic? Can you decrease the dose? Can you discontinue the dose? So the government has really kind of identified this as one of the key areas for improving prescribing in elderly. And the reason why is FDA came out with information that said it increases CVA and cardiovascular mortality, particularly in patients with dementia. So maybe 15 years ago, every patient that had dementia and kind of some behavioral disturbances was given Haldol, right? Like that was a pretty common thing, or risperidone, and now there's a real push to kind of move away from that or use the smallest dose that you can to manage in these patients. Insulin sliding scale, and these are kind of some older medications for using diabetes, and essentially, you know, for sliding scale, you see too much hypoglycemia in these patients, and it's not the most effective way to manage that. And then the same for like glyburide. Glyburide, again, is a medication that's renally eliminated. So if the medication is not being eliminated, then the patient's going to be more likely to have hypoglycemia. We'll talk a little bit more about benzodiazepines later, so I don't want to spoil the surprise. Reglan is a good drug. So in patients, especially in elderly patients, unless they have gastroparesis, there's a real indication for that. But a lot of times, some physicians are still using it for nausea and vomiting. And maybe that's not the most appropriate drug for nausea and vomiting, because you do see a lot of movement disorders in patients, especially with higher doses in the elderly patients. Also, non-COX inhibitors and NSAIDs. So patients are more likely to have GI bleeding. And so chronic use, you know, it's appropriate for acute use, particularly acute pain, but for chronic use, they're going to be more likely to develop GI bleeds. So this is category 2 drugs. So remember, like I said, category 2 are drugs that potentially, if a patient has a disease, are not the most appropriate drugs to use. And so if a patient has syncope, again, you worry about orthostatic hypotension or bradycardia, so acetylcholinesterase inhibitors. So what are those, right? So those are the meds that we use for Alzheimer's. So galantamine, rivastigmine, those are all your acetylcholinesterase inhibitors. and so you're going to see more dizziness and potential problems in those patients. Also, alpha blockers is another drug. So drugs that are used for BPH, like trazodone, Pitrin, those kind of medications, again, you're going to see a lot of orthostatic hypotension. And then in patients that have insomnia, basically any medication that can exacerbate their insomnia. So pseudoephedrine is a really good example of meds that will make a patient not be able to sleep. And then category 3 is drugs used with caution. And I just threw this in here. So Pradaxa, that's a new anticoagulant. Have you guys started seeing patients on some of the new anticoagulants? No? So Pradaxa is a new one, and this was actually one of the first new oral anticoagulants that came to market. And there was a real push to use this in atrial fibrillation in elderly patients. So that was kind of what the market was, is elderly patients, right? And these elderly patients that were getting Pradaxa had an increased risk of bleeding. And so, that's something that really, I saw maybe a couple months where Pradaxa use increased in elderly patients, and really the shift's gone away from it because, if you look in the news and just the newspapers, it talks about Pradaxa and bleeding in elderly patients. So that's one used with caution, but I would almost move it to one of the other categories. And then drugs that are linked to SIADH or hyponatremia. So a lot of your SSRIs and tricyclic antidepressants and antipsychotics all can cause hyponatremia through SIADH. So those are drugs just used with caution. So the Beers criteria, it's only one part of quality prescribing. It's guidance and it's not complete. And then, so this came out in 1991. So that's how long? 30 years ago? 30? 30 or 40?
20.
20, okay. I'm better at math than that. So this came out in 1991, and let's think about, did this make an impact? Because if I'm looking at these drugs, I would think, boy, I'm not going to use these medications, right? Like these are inappropriate, like you're telling me some of them don't work, some of them are going to cause falling, but they're still really common. So, this was a study of patients in nursing homes, and it was done by the VA. And so 93% of patients were still on one drug that was on the Beers list, 18% were on 2, and 2% were on 3. So that's kind of interesting that these drugs have been around, they know that there's known side effects, but they're still pretty common in your patients. So another tool that, oh yeah.
What do your pharmacists do when a patient comes in with Beers list drugs on their drug sheet, on their meds list?
So if it's part of the senior ER, then the pharmacist will review it and then they'll make a recommendation for a different medication. And actually any patient in the pharmacy here, we know that the patient's on one of these medications and we get an alert in the pharmacy, so then the pharmacist will call the physician.
Oh, okay.
That being said, I'm not saying that these drugs, you should never use it, because obviously some medications patients need, some patients need these medications, but if there's a safer alternative, then the safer alternative should be used. So this is a new criteria. This one, so Beers criteria came out in 1991, and this came out in 2005, so this is a lot newer. And this is the stop and start criteria. So stop is screening tool of older persons on potentially inappropriate prescriptions. And start is screening tool to alert doctors to the right treatment. So these are meant to be used together. And I think it's kind of a really innovative idea, this approach. So they're looking at meds that patients are on that they shouldn't be on, and also thinking about meds that patients need as well. So that's something we're always like, oh, stop that, stop that, stop that. And a lot of times patients need to have medications as well. So it's a little bit different. So these are some kind of common drugs in the stop criteria, and I think the stop criteria is 55 drugs or something like that. So this isn't all of them, but this is some of them. So if you have a patient that has hypertension and an elderly patient, starting a loop diuretic as first-line therapy is not appropriate. So why do you guys think that? That's right. Calm down, not everybody at once. So I just told you before more that they're more sensitive to these medications. They're more sensitive to developing electrolyte abnormalities. So we don't see a lot of the electrolyte abnormalities with some other types of medications. So that's why it might not be the best drug. Aspirin at doses greater than 150 milligrams a day. So they have enough studies, and there's kind of sound enough literature that in elderly patients, doses of 150 milligrams above that doesn't have any additional benefits to the patient. So you have additional risk if you're giving an elderly patient 325 milligrams without an additional benefit. So does that make sense? Mm-hmm. Long-term benzodiazepines or benzos with long-acting metabolites. So I just told you before, there's two phases of metabolism, right? There's the oxidative and the conjugative metabolism. So the benzos are metabolized differently. If a benzodiazepine is metabolized with your cytochrome P450s, those are less preferable drugs to use in elderly patients. So a drug like Valium is metabolized in that mechanism, and so it's a less preferable drug. Also, Xanax is another medication in the elderly that's metabolized in that manner because, again, their metabolism with the P450s is less effective. It's interesting because I think in like 1960 there was a study in New England Journal of Medicine that looked at benzodiazepine half-life in elderly patients, and it was actually medical school students and their teachers. So I'm using the word elderly, but they were like 50-year-old professors. So so that's kind of, so it's not elderly, so it's just older than the medical school students. It's like, did your speaker alienate the audience? And then, don't include that question, Kelly. So they looked at the half-life and how long these drugs were sticking around in the professors versus the students, and they found 2 or 3 additional days that these medications were sticking around in 50-year-old people versus medical school students. So it kind of gives you a perspective of, starting at age 50, you're going to start seeing a difference in benzodiazepine metabolism, which we're not talking about like 65 or 80. So it's kind of a good perspective on how young that happens. And then duplicate medications. So patients shouldn't be taking 2 or more NSAIDs or 2 or more benzodiazepines together. So again, that's just because of additive effects. So I'm not going to talk about all of them, but do you guys have any questions about any of those that you're like, why is that on there or anything?
What do the numbers mean? I mean, they should be taking 3 different loop diuretics?
Oh, no, that's numbers. No, that's numbers from the list. So that's a good question, though. Okay, so we just talked about medications that we should be stopping. Let's talk a little bit about medications that we should be starting. So these are medications that a patient really should be on. So if a patient has a history of atrial fibrillation or if they have atrial fibrillation, they should be on warfarin as long as they don't have any contraindications to it. If they do have a contraindication, then they should potentially be taking aspirin. A couple others. Levodopa in Parkinson's disease is another one. If a patient has COPD, essentially they should be taking a beta-2 agonist for their COPD. Okay, let's see. 3 minutes to talk about this. Okay. So obviously, I probably don't tell you guys, medications and falls are pretty predominant problem, right? So falls are the leading cause of injury in adults over 65. This is kind of mind-blowing to me. This is an annual cost of healthcare attributed to falls, which is $28 billion, which is just insane to me. And approximately 1/3 of community dwelling patients will experience about 1 fall a year. And I think as patients are over 80 years old, 1 in 2 will experience a fall in a community dwelling situation. So these are kind of common risk factors done in falls. Like falls are such a huge problem. They say in the next 5 years, falls are probably going to be one of the hugest healthcare problems and healthcare dilemmas that we're facing. So they've done all these studies to look at falls, and obviously some of them you can change. So medications is one potentially that you can change. This is from a meta-analysis, which I thought was really interesting. So you look at odds ratio, your likelihood for developing a fall, essentially, is kind of what our odds ratio is, and it gives us our confidence interval. So if your confidence interval includes 1, then it's not statistically significant. If it does not include 1, so if it's on either side of 1, then it's a significant risk associated with it. So we can see antihypertensives are 1, neuroleptics, antidepressants, and kind of interestingly, NSAIDs, because I was thinking that was kind of interesting. So antihypertensives, obviously the main mechanism by which falling is happening is orthostatic hypotension. During the first 14 days, it's been found that patients are more likely to experiencing falls, and that's because of their body's compensatory mechanism isn't as effective. So that's one thing, thinking about your patients and thinking about your therapy, if you're looking at them, if they've been on a hypertensive for a long time, that's probably not what's causing their falling. But if it's newly starting an antihypertensive, that's the time we're going to see more likelihood for that. Antidepressants, again, we talked about tricyclic antidepressants being on the Beers criteria and the start-stop criteria, but the risk is about the same between tricyclics and SSRIs. And so again, this is because of insomnia. So a lot of the medications cause more insomnia. A lot of the medications cause more sedation. So that's kind of a balance of why we're seeing more falls. It's interesting, though, that the risk of falling for a patient is about the same if they're on an antidepressant or if they have untreated depression. So it's kind of a catch-22. And NSAIDs and falls, you can read. So just some conclusions. So elderly patients are a growing population. There are significant challenges when managing their medication, so I just told you all of the changes. What's kind of a positive thing is there are some tools in place, so we can look at medications and determine if they're inappropriate or if there's better alternatives. And it's just really helpful kind of to work as a healthcare team, right? So anytime someone on a healthcare team is more educated about something, they can contribute something different. So I think kind of the end result of us working on a team and looking at these side effects in elderly and medications as a whole is having safer patients. So that's kind of it.
No, go ahead. Back on the causes of falls, it's, obviously that's a pretty big list. Is there a number where it significantly increases the risk? Like if there's more than 2, more than 5 of these indicators, that it significantly increases the risk for falls?
Gina, I didn't see that specifically called out, but I did find that most falls, it's not one singular cause. They said generally for falls, it's kind of a multifaceted problem, but I didn't see a tipping point for it.
Thank you.
Well, I hope you guys found that informative.
Thank you, Rachel. All right, so just to wrap up, I wanted to remind everybody that today starts the Culture of Safety / Harmonized Survey. So for those of you in home care, you'll get your letters when, or did they already get them? Okay, they'll be in the office today. Hospital staff, contingent staff, I have your letters here if you want to come up and get them. You can do them before you leave today if you'd like to. Wellness staff, you'll get your letters tomorrow at our team meeting. So those are already over at the Wellness Center. I just wanted to thank everybody for coming. I think it's been an exciting morning. I apologize we got started late, so we were kind of rushing through a couple of our presentations. So big apologies to Audrey because hers was a really good presentation, so sorry about that. Just a reminder, Kim is going to gather your packets as you leave. So remember, you'll need to hand in this stapled packet and your evaluation form, and you guys are good to go. Thank you.